Well, the major point is that in Europe, we don't have access to genomic testing, except, for instance, BRCA testing that we have, so the germline or somatic testing on tissue. But we don't usually use other genomic tests like Decipher and so forth. So we are used to work with clinical parameters. We use a lot of PET-CT, so PSMA PET-CT, which is not new in Europe. It may be new now in the US, but we've been using all these features, clinical features, for a long time, and we actually feel that it works very well in clinical practice. And the second point is that all clinical trials so far have been based on classical staging, on classical parameters. So all the risk groups we use in clinical practice and all the trials showing advantage of certain treatments in certain risk groups, clinically and pathologically defined, are what we have to work with. So if you change all of that by using genomic markers and redefine risk groups based on genomic markers, we also have to redefine treatments sometimes, and that becomes a little bit complex in my view. So I'm not against genomic markers at all, but I'm just saying that in clinical practice, we don't use them yet. In Europe, we are using the clinical risk groups, which are defined in all the guidelines, and we are using imaging and advanced imaging much more often than we used to before, and it works just great.